Hi, I'm Conrad Fisher. This is our next section of congestive heart failure, CHF. A 62-year-old man with hypertension dyslipidemia comes with shortness of breath or dyspnea, lower extremity edema for the last 2 months. There's jugular venous distension, S3 gallop from that rapid filling, and an apical impulse that's displaced to the left because of left ventricular hypertrophy as it shoots over to the left side of the heart. The chest X-ray shows an enlarged cardiac silhouette, which goes along with the displaced PMI, and echocardiography, which is the only way to be able to tell the difference between systolic and diastolic dysfunction, shows a dilated left ventricle with a low ejection fraction, 35%, the magic number where all evil begins. The pathophysiology of heart failure is that there's an inability of the ventricles to get blood effectively through. Now, that can be both diastolic dysfunction, meaning that they can contract but they can't relax, or systolic dysfunction, meaning it can relax but can't contract. But functionally, they are the same. It's the inability of the ventricles to effectively pump blood through the circulation. Now, there's compensatory changes in vascular function. The blood volume goes up. The neurohumoral status, what does that mean? It means that the kidneys perceive that there's low perfusion and you make more renin. And it means that your atria and your carotids perceive less volume and there's more ADH. You could think of CHF as an appropriate increase in antidiuretic hormone, and they increase the volume, and then the body has to make a decision. Oh my god, do you want to maintain the volume, but you know the sodium's going to go down? Yeah, but we got to get the volume. Yeah, but we want to keep the sodium. Yeah, but the volume, but the sodium, but the volume, but the sodium. Which one wins? Perfusion or sodium? And the answer is volume. Volume status beats a normal sodium. That's why there's an increase in ADH to maintain that perfusion pressure, because you gotta be alive to have a normal sodium. It's better to be alive with a low sodium than dead with a normal sodium. The mechanism that deteriorate cardiac function over time, basically you jump off the Frank Starling diving board there, you overstretch, increasing that end diastolic volume, overstretch, and eventually, even though it fills, the stroke volume goes down, the cardiac output goes down. Now, until you markedly overstretch a heart, more filling means more function. But this is so overstretched, you get to a point where systolic function goes down. But you remember, for a long time, more volume, more performance. But this is overstretched critically. You get a low ejection fraction from systolic dysfunction and impaired filling, impaired relaxation from diastolic dysfunction. Both of them result in a tachycardia. And both of them can give you an abnormal shape of the heart, whether it's dilation or hypertrophy. Now, once a heart dilates or becomes thick, once the heart changes in shape, what can be done to restore it to normal size and shape? The answer is nothing. When your underwear stretches up in size, what can you do to restore it to normal size and shape? You can't do anything. You gotta do an underwear transplant. You can't do an underwearoplasty. That's right. The only thing you can do to change your heart once it's changed its shape is you've got to change the heart. That's why all treatments have to be done before you shape change in the heart. All the treatments have to be done before the shape changes. Further mechanisms that make the heart deteriorate in its function is a sympathetic adrenergic activity. That's why beta blockers are so good. And there's hormonal things, meaning increase in the renin, angiotensin, aldosterone system. And remember, even though it might say vasopressin at 1 minute, the next minute could say antidiuretic hormone. What's the difference between antidiuretic hormone and vasopressin? Nothing, just the amount. At low amount, it's ADH. At high amount, it's vasopressin. Which is the body more sensitive to? Changes in volume or changes in osmolality? Which is it more sensitive to? Volume or dryness? The answer is the body's more sensitive to dryness. So when you get to the point of vasopressin, that's a major circulatory abnormality. It's a 1% change in osmolality, but a 10% change in bodily volume. And that's what makes the ADH or vasopressin increase. There's increase in catecholamines, and again, that's why beta blockers help. If you look at all the treatments for CHF, the ones that interfere, block, or interrupt the renin-angiotensin-aldosterone system are the ones that lower mortality. I'm going to leave you to absorb this mechanism slide, which looks a little like trying to scratch your shoulder by reaching through your fly, as it goes from decreased LV function to decreased cardiac output to arterial or constriction, decreased kidney perfusion. You need a minute to meditate on this slide and think it through for yourself. Systolic heart failure is heart failure that is from a loss of contractile strength accompanied by ventricular dilation. This is when there's a decrease in normal ejection fraction. It goes under 45%. Now, normal ejection fraction is actually 55 to 70, but there's absolutely no symptoms till you go under 45. And matter of fact, most people don't have symptoms till you hit 35% of ejection fraction. So that's what's saying that an ejection fraction at 45 or above is completely asymptomatic. Whether you start to have symptoms at 40 or 35 depends on the person. So above 45% ejection fraction, definitely asymptomatic. Below 35%, definitely start to be symptomatic. An example of this is ischemic cardiomyopathy, which causes dilated cardiomyopathy because it's dead, and dead things don't move. Write that down. Dead things don't move. Diastolic heart failure is with dysfunction with a normal ejection fraction. Sometimes it's called congestive failure with preserved ejection fraction. You preserved it. I'm tense and nervous and I can't relax. And when filling of one or both ventricles impaired, the emptying capacity is normal, but the filling capacity is not. And that's things like sarcoid, amyloid, hemochromatosis, cancer and fibrosis, sarcoid, amyloid, hemochromatosis, cancer and fibrosis that impair the ability of the heart to relax. Decompensated heart failure is worsening of symptoms. This doesn't happen in a normal heart. You can't suddenly get pulmonary edema from a normal heart. You eat a piece of pizza or have some pepperoni pizza and all of a sudden some extra salty potato chips and you go into flash pulmonary edema. Those people are not normal. The precipitating factors of non-compliance or non-adherence to meds or the pizza, potato chip, 100% chorizo diet of the extra salt, that's not going to do it to a normal person. But ischemia, tachycardia, and infection take it when you have a person who's got underlying congestive failure and then they become suddenly worse. But that's not a normal person. In assessing for precipitating factors, you start with the most dangerous thing first. Ischemia, arrhythmia, infection, non-compliance. Ischemia, arrhythmia, infection, non-compliance. Ischemia, arrhythmia, infection, non-compliance. Give me the one most dangerous. Give me that one that's going to kill you. Ischemia, arrhythmia, infection, non-compliance. That's what precipitates pulmonary edema. Now, in addition to that, thyroid problems and uncontrolled hypertension can do it, and anemia, because if you don't have enough oxygen carrying capacity, it can precipitate congestive failure. The symptoms of congestive heart failure are shortness of breath, orthopnea. I'm laying flat, I feel short of breath. I stand up, I feel better. Paroxysmal nocturnal dyspnea, when you lie flat when you're asleep and the blood pools in your lungs. And of course you feel tired and weak. You can't pump any blood to your tissues, so you feel tired, man. Your waiter doesn't deliver your food, you feel hungry. Your heart doesn't deliver any blood, you feel tired. On physical examination, you'll have rales, sometimes called crackles, peripheral edema, ascites, big liver, big spleen, jugular venous distension, and a displaced apical impulse because it's part of left ventricular hypertrophy or enlargement. The left ventricle hypertrophies to the left. That's why we call it the left ventricle, because it hypertrophies to the left. Now, generally speaking, I'm not a big fan of having to have you sit there and memorize every class. There's 4 classes. Class 1 basically means you don't feel it unless you do profound exertion. In other words, there's no limitations. You don't feel much of anything, and you don't feel anything at rest. You don't feel anything with normal activities. In other words, if you're an ordinary person, you won't feel it at all. Class 2 basically means that if you're walking up a couple flights of stairs, you'll feel something, but again, there's no symptoms at rest. Class 3 means any amount of activity. Any amount of activity will make you short of breath. And Class 4 just basically means that you're so short of breath you feel it at rest. When you're a student or working as a doctor in a hospital, most people have never seen anything that wasn't Class 3 or Class 4. Because if it wasn't Class 3 or Class 4, it isn't admitted. An echocardiogram is the test that diagnoses the degree of ejection fraction dysfunction, valvular heart disease, and wall motion abnormalities. Now, it is the answer definitely to what's used in everybody, but it's not the answer to the question, what is the most accurate method of assessing ejection fraction? What is the most accurate? Is the MUGA scan, the nuclear ventriculogram, is the most accurate. What do I do? Echo. What's the most accurate? MUGA. The chest X-ray will find 4 things. An enlarged heart, cardiomegaly. Vascular redistribution, which means normally most of the blood flow is at the bases of the lungs, and this redistributes towards the head. Curly B lines. Curly B lines are more important for a step 2 exam than they are for real life. Curly B lines ceased to be important when the echo was invented, but you can still be asked to know what they are. Curly B lines is fluid in the interlobular septa. Each lobe has several lobules. When you have fluid accumulating outside the lobules, it's curly B lines. It's a form of interstitial edema. The electrocardiogram shows ventricular hypertrophy, sometimes ischemic heart disease, sometimes arrhythmia or conduction delays. The arrhythmias are particularly important in acute exacerbation of CHF. Normally, the atrium only contributes 10 to 15% to cardiac output. But when you have a person who's got a dilated heart, a weak heart, an inefficient heart, a heart that pumps blood the wrong way, get back there, get into the ventricle, you're pumping the wrong way! And then you lose the atrium, oh my God, ay Dios mío, it goes backwards, it goes in the wrong direction. And in a person who's got a leaky heart, a weak heart, a partially dead heart, atrial fibrillation, atrial flutter, SVT can put you in pulmonary edema because in a sick, abnormal heart, the atrial contribution can now become 30 or 40 or 50%. In a normal heart, it's 10 or 15%. But in an abnormal heart, it's 30 or 40 or 50%. The BNP, or brain natriuretic peptide, is the same thing as saying atrial natriuretic peptide. It's a polypeptide secreted by the heart in response to excess stretching in the myocytes in the atrium. Now, BNP that's normal excludes CHF. A normal excludes it. An elevated is rather non-specific. But the BNP is something that you get if you're equivocal of the diagnosis, and a normal excludes CHF. Atrial natriuretic peptide, or brain natriuretic peptide, is a weak diuretic that makes you remove sodium and water from the body and result from atrial stretch. Let's talk about treatment of CHF. You got to improve those hemodynamics, relieve those symptoms, prolong that survival, and treat the underlying cause, fix those reversible causes. Non-pharmacologic treatment is stop eating so much salt. Weigh yourself. Exercise. If you're in acute pulmonary edema, sit up. Put your feet down, your head up. Feet down, head up. Feet down, head up. What's the best initial therapy? Well, for systolic dysfunction, it's very clear. ACE inhibitors are used, even if the blood pressure is normal, to help the forward flow of blood. ACE inhibitors improve survival. They stop the heart from changing shape so much. They reduce preload and afterload. Mostly they reduce afterload, and the ACE inhibitors are a class effect. It doesn't matter which one you're using. They're all identical. So whether it's captopril, enalapril, lisinopril, moexapril, fosinapril, any pril, they're all equal. Now, if a person has a cough, use angiotensin receptor blockers, ARBs. Now, losartan, valsartan, irbesartan, candesartan, losartan, valsartan, irbesartan, candesartan, losartan, valsartan, irbesartan, candesartan are all identical. It's a class effect. It doesn't matter which one you use. And for those who can't tolerate an ACE inhibitor from cough or angioedema or allergy. Remember, ACE inhibitors are highly allergenic. What are you going to do if you have hyperkalemia? Can you use an ARB? No, you can't, because ARBs are going to inhibit aldosterone, and you're going to get hyperkalemia too. If you have very severe hyperkalemia you can't get rid of, use hydralazine and nitrates as afterload reduction. hydralazine, and nitrates. Diuretics are a treatment for acute pulmonary edema. Now, in acute pulmonary edema, diuretics are first for sure because you want to remove volume with the loop diuretics, volume first. Thiazides are used mostly just to control high blood pressure. They're not specific to congestive heart failure. Spironolactone does not work as a diuretic. Yes, it's always listed under diuretics, but how it works is by being an aldosterone antagonist. You add it on to ACE and beta blockers to lower mortality. That's one of the biggest issues. Which of the following lowers mortality? Spironolactone and eplerenone lower mortality. Spironolactone is a great drug. We love the fact that it was found by accident to lower mortality in CHF. It was invented as a potassium-sparing diuretic in the 1950s and 60s. And it's for people who have severe CHF. Severe means class 3 or 4, meaning shortness of breath with exercise or even at rest. Shortness of breath with any exertion or even at rest. Definitely reduces deaths and hospitalizations, but only for severe class 3 and 4 disease. It can cause hyperkalemia because it inhibits aldosterone, and potassium is excreted by aldosterone, so since it inhibits aldosterone, you retain potassium. Eplerenone is used because spironolactone is massively anti-androgenic. Spironolactone is so anti-androgenic, we use it for polycystic ovaries. It brings your ovaries back to life when they're running scared from all those androgens. And so spironolactone is massively anti-androgenic. Do you have unsightly hair? Not having enough periods? Not fertilizing you like you'd like to? Try our special old spironolactone, and those ovaries will come back to life, and you'll be less hairy too. In diuretics, the most important thing is that you control the blood pressure. So loop diuretics are useful for acute pulmonary edema. Thiazides are for hypertension. Now, one of the things that people don't realize is that there's more than one thiazide. There's hydrochlorothiazide and chlorthalidone, chlorothiazide, and they work in the distal tubule, and their adverse effects are hypokalemia, because you're causing increased urinary loss of potassium, hypercalcemia, because the distal tubules where calcium is absorbed in the kidney, metabolic alkalosis, because you're increasing the excretion of potassium, because any volume depletion increases aldosterone. Volume depletion increases aldosterone. Hyperuricemia because of increased absorption. And the issue of agranulocytosis and pancreatitis is the same way that you can get a rash with a sulfa drug. Well, thiazides are a sulfa derivative. And as such, you can get pancreatitis because it's a sulfa derivative. And you can get a person who's got an allergic reaction in their bone marrow. Indapamide is another diuretic. We don't use it too much, but you can get some hypokalemia and lipid abnormalities as well. Loop diuretics are most often used in heart failure. They make you lose volume. They cause a loss of calcium. That's the biggest difference. The single biggest difference is low calcium, because the distal tubule, you increase calcium absorption, but loop diuretics make you lose calcium. Loop diuretics make you lose calcium. And the diuretics of eplerenone and spironolactone cause hyperkalemia. Gynecomastia is only with the spironolactone. Beta blockers lower mortality. They increase ejection fraction. Can you believe that's hard for people to quite understand that? How can a negative inotrope be increasing ejection fraction? How can a negative inotrope be increasing stroke volume? How can it increase cardiac output? Because when you are anti-ischemic, the heart beats more efficiently. When you're anti-ischemic, the heart relaxes and it beats more efficiently. It fills more and it beats more efficiently. And beta blockers not only reduce hospitalizations, but they have a massive effect on lowering mortality. How do you die of pulmonary edema? You die not of drowning to death in the hospital, but of sudden death from ischemia-mediated arrhythmia. And beta blockers are both anti-arrhythmic and anti-ischemic. When vasodilators like ACE inhibitors and ARBs can't be used because you got worsening renal failure or because you have an intolerable hyperkalemia, we can use hydralazine. Just remember, hydralazine has to be used in combination with nitrates for it to reduce death. See, without the nitrates, hydralazine would steal blood away from the coronaries. So what we do is we use hydralazine to vasodilate and nitrates to dilate the coronaries so it doesn't steal the blood away from the heart. ACE inhibitors, enalapril, captopril, lisinopril, are all mostly arterial vasodilators. These are all oral, although there is one IV an ACE inhibitor called enalaprilat. And ACE inhibitors, besides making a cough and sometimes causing renal failure, also give dysgeusia, which is a taste disturbance. The reason for that is not clear. And the agranulocytosis is an allergic reaction. Nitroprusside is very rarely used, but it can be used acutely as a vasodilator. Nitroglycerin is often used in acute pulmonary edema because venous dilation will pull blood out of the lungs and decrease the volume in the lungs. Because it also dilates the veins of the head, it can cause a headache. Because anything that's a venous dilator in the brain can cause headache, a pounding headache. And all nitrates can cause methemoglobinemia. And whether it's IV nitroglycerin or isosorbide dinitrate, they fundamentally work the same. Hydralazine is exclusively arteriolar, and although people often have positive ANA, actual lupus-like symptoms are relatively rare. Inotropic agents don't lower mortality. They decrease symptoms, they decrease rates of hospitalizations. Digoxin, digitalis, decrease hospitalization, decrease symptoms, but they don't improve survival. And that's the number one question. You've got to know which things improve symptoms, but which improve survival. ACE, ARB, hydralazine improves survival. Beta blockers and spironolactone improve survival. Digoxin and diuretics improve symptoms. The mechanism of congestive heart failure management with digoxin is not as important on step 2 as it is on step 1. It inhibits the sodium-potassium ATPase. And what this basically does is leave extra calcium intracellularly for a person's myocytes, which increase the contractility. Basically, by competing with potassium for sodium-potassium ATPase and inhibiting the sodium-potassium ATPase, you leave calcium there for more cross-bridge cycling. And that extra calcium increases the force of contraction. It's a great idea. It doesn't lower mortality, but it's a great idea. Since potassium and digoxin and digitalis compete for the binding site, every time you have hypokalemia, you're more likely to have more digoxin toxicity. Digoxin toxicity can be predisposed by renal insufficiency where it accumulates, electrolyte disturbance like low potassium, advancing age, and the more underlying cardiac conduction defect there is, like SA and AV node block, the more likely there is to be digoxin toxicity. Because the more vulnerable and abnormal the conduction system, the more vulnerable and more likely you are to have a conduction block. The symptoms are GI. The most common toxicities finding of digoxin is GI. Gynecomastia happens over a long time, but GI, nausea, vomiting, diarrhea is the most common. Blurry vision and yellow halos around the objects. And what arrhythmia can you get with digoxin? You can get any arrhythmia. What's the most common? SVT with block. Paroxysmal atrial tachycardia with variable block. What can you get? Anything. What's most common? Paroxysmal atrial tachycardia with variable block. So stop the drug. If you actually have an arrhythmia, we use phenytoin. Lidocaine's okay, but digoxin toxicity, when it was much more common, the drug of choice for dig toxicity was phenytoin. You mean phenytoin? You mean the seizure medication phenytoin? Yeah, because phenytoin is a class 1B antiarrhythmic in the same class as lidocaine. Oh, really? Yeah, really. Digibind is digoxin binding antibodies, and we use that for people who have CNS and cardiac problems. CNS and cardiac problems, that's the indication for digoxin binding antibodies. Sympathomimetic agents such as dopamine and dobutamine are only used in the very rare person who's admitted for acute pulmonary edema who doesn't respond to preload reduction. If you have a person that responds to preload reduction with morphine nitrates, diuretics, morphine nitrates and diuretics, we are not going to use these acute inotropic agents. Now, dobutamine is a positive inotrope that does vasodilation. So dobutamine is much more useful than dopamine. Dopamine is a positive inotrope, and so is dobutamine. They both increase contractility, but dopamine has alpha activity that causes vasoconstriction. Dobutamine is a vasodilator. They do the same thing as the phosphodiesterase emitters do, which is amrinone and milrinone, and they're used in severe acute pulmonary edema not responsive to preload reduction. We're going to look at fluid, the intake and outtake, and make sure that people are losing weight. You see, weight gain is one of the first clues that somebody's CHF management is failing. If you're putting on pound after pound after pound of water weight, it means your CHF management is failing. Now, the goal in diastolic heart failure is to slow that rate with a beta blocker and calcium channel blocker sometimes, but the problem is calcium channel blockers like nifedipine often increase heart rate. So we just have to slow heart rate with things like diltiazem and verapamil in some people. The vast majority of the time, we want to just be able to use a beta blocker to be able to slow the heart rate. Diastolic heart failure can worsen with diuretics, and the problem is we don't have a clear drug that lowers mortality in diastolic heart failure. In systolic, we have many things. ACE inhibitors lower mortality, beta blockers lower mortality, spironolactone lowers mortality. But in diastolic dysfunction, nothing clearly lowers mortality. A biventricular pacer is used if we have a person who's got a wide QRS. A wide QRS means that you need to resynchronize that heart. Resynchronization causes the left and right ventricles to be able to beat more in uniformity and increase the forward flow of blood. So biventricular pacemakers are what we do when people have a wide QRS. Implantable defibrillators are what you do for people at very low ejection fractions, less than 30 or 35%, and they really lower mortality because, after all, what's the most common reason to die in congestive failure? The most common reason to die in congestive failure is sudden death from ischemia-mediated arrhythmia. So therefore, an implantable defibrillator that stops the arrhythmia lowers mortality. When all else fails, we have to transplant. A dilated cardiomyopathy with an ejection fraction less than 35% is an indication for an implantable defibrillator if it doesn't improve with medications. Pulmonary edema is a medical emergency. You're going to drown to death and drown in your own fluids and become hypoxic right away. And you have a person with pulmonary edema, the key issue is to get the fluid out of the lungs so you can physically remove a liter of fluid from the chest and you stop having shortness of breath and cough and pink frothy sputum and feeling blue and cyanotic and nocturnal dyspnea and rales, rhonchi, and wheezing. Pulmonary edema, take out the volume. In cardiogenic pulmonary edema, the chest X-ray will show curly B lines and big, juicy, plump vessels towards your head, or a cephalization of flow. Remember that the key issue is in acute pulmonary edema, ACE inhibitors are not as important as removing volume physically from the blood vessel system. Physically remove volume with diuretics only in acute pulmonary edema. The EKG is to see if there is an arrhythmia that caused the flash pulmonary edema. That's the point of doing an EKG in pulmonary edema, to see if there is an arrhythmia that threw you into it. In acute pulmonary edema, sit that patient up, give them oxygen, diuretics, nitrates, preload reduction, nitroglycerin, venous dilator, nitroglycerin, venous dilator, preload reduction. Morphine dilates veins in the lungs. Morphine sulfate dilates veins in the lungs, preload reduction with morphine sulfate. Digoxin is not for acute pulmonary edema. Digoxin does nothing acutely. It slows down the heart rate. So if there's atrial fibrillation, you can slow down the heart rate with digoxin. But digoxin as an inotrope will do nothing acutely. ACE inhibitors are not as important acutely. What you use acutely is preload reduction, and if it persists, positive inotropes. Dobutamine, imandronone, milrinone, and occasionally hydralazine. Dopamine is the answer only if there's low blood pressure as a pressor. See you in the next section.